know, how exciting about that. To quiz you on this information that you're gonna get today is really kind of, there's no purpose in it, because what we're going to go through today is we're going to look at the new standards of practice, the new education standards, the new scope of practice, and we have to kind of do this information to go ahead and bring you up to the education. So, disclaimer, I'm going to read it to you. This content is not designed to teach you new skills, but to bridge the education from what was taught years ago to what is being taught now. Some of the ways we handle patients is being used, some of the way I didn't write that very good, some of the way we handle patients is being used now. So some of the things that you're going to see that we talked about today, you might see new paramedics coming out and doing some of this information. But with the new National Standards of Education, all you old guys in the room that have been paramedics for many, many years have to be taught this new stuff. We probably won't see some of this stuff on the ambulances in our area because it's just not feasible to do so. But some of the things in the way we teach our or treat our patients, you might start seeing some of the new paramedics do it. So I know that you sit here and you say, well, why do we have to go through this if we're not doing anything of it? It's this bridge class. Ultimately, if you guys were around in 2007, end of 2006, 2008, we had to do that bridge for everybody to get you guys the new information. And that's all this basically is also, so. As far as who develops this education, years ago it was the DOT that would put all of this information together and they would say, this is what paramedics, this is what EMTs can do. Things have changed a little bit as far as EMS. We're starting to really grow up as a profession, and there's a lot of big organizations that do have a say or have partnered to come up with what's the best practice. So, there was the education agenda for the future. That expired in 2010. So there has been many partners that have worked throughout the last couple of years putting the new agenda for the future of 2050 together. Where do we want EMS to be in 2050? That's really what they're looking at there. Document, if you're interested, you can just look on ems.gov. It's probably about 80 pages, good sleeping document to read if you're having insomnia. Then we have the National Standards of Education and Instructional Guidelines. Those are coming from the national state offices, the national EMS physicians. And what they've done is they've taken, looking at the whole United States, and said, okay, what can everybody do? Now, we have some that will do very minor things. I'll be honest with you, Illinois is really behind the ball games. All these things that we're going to talk about, services are doing all around us. Wisconsin, Iowa, down south in Carolina, Texas, Washington. Washington's actually very instrumental in helping us come up with best practices. And so they've taken this information from all throughout, said, yeah, this is what we can teach these paramedics to do. And then we have the new national EMS scope of practice model. These are like a set of protocols for the United States. This is basically saying all paramedics should be taught how to treat a patient this way. You know, when you go to the hospital, you take a look at nurses. It's called the, you're going to take notes?
No. I make airplanes.
I was getting excited there. So, when they talk about care plans for patients in the hospitals, that's really what they're looking at for us pre-hospital. Now, they have changed the names of what they call us. We used to be EMT Basic, EMTI, EMT Paramedic. They changed the names. First of all, they dropped the EMT off of paramedic. We are just considered paramedics now. They've taken away the level of the EMTI and made it an AEMT, an advanced EMT. And then you have EMT, so they've dropped the basic, and then you have what we call EMR, which is our first responders, which was the level before. So with these new name changes everybody's scope of practice. Now, what is scope of practice? Scope of practice does not define a standard of care. Scope of practice is just a list of all the different things that you can do as a paramedic, an EMT, whatever level you are. It is designed to give you some sort of working guidelines as to how to treat your patients. But you do have to be licensed. Scope of practice is different than standard of care. Now, standard of care, everybody knows, what would a prudent paramedic do if they were in the same or similar situations? How would they act? What was their defining? What is reasonable for an EMS person to do? Are we doing the right thing? And that's the difference between the two. Scope of practice is like what we follow with our general protocol. Standard of care, even though we have protocols, our standard of care says, well, let's take a heroin addict for an example here. Our protocols say if we have someone with a narcotic overdose, we assist ventilations. We give them 2 milligrams of Narcan. Reassess every, 15 to 20 minutes. But if you are one of those providers that says, okay, I'm going to go ahead and ventilate this patient knowing that they've been down for a while, their metabolic acidosis is up for a little bit. If we use our bag valve mask, we can kind of change their metabolic acidosis to come back to a homostasis type level. And then we can go ahead and give them not 2 milligrams of Narcan, but only enough Narcan to go ahead and increase the respiratory rate, because that's what Narcan does, is we give it for respiratory rates. We don't give it for, removing the narcotic from their system. Two different things. You don't follow a protocol, you do the standard of care. Are you wrong? No, not necessarily. You are actually doing what you feel is best for the patient. And if you talk to a lot of other paramedics in the same situation, they might be doing the same thing. Now, the way we teach is going to change quite a bit, and we model our paramedic program after this. So, first of all, you go to school, you become educated, right? You are taught how to go ahead and perform certain skills. You're taught how to assess a patient. And this we learn in whatever class we're attending. From there, we become certified as being competent. We put people through evaluations, something that we can measure. Can they do the skill? Are they competent at that skill? Once they become competent at that skill, then the next thing is they get their state license and they get to practice. A state license is, or licensure, is a governmental agency is giving us the authority to perform certain skills based on whatever the medical director has stated. So, anybody can get it, when you get your state license, you don't know exactly what you're going to be certified to actually perform as far as skills are concerned. Not until you become credentialed by your medical director. Or the system in Illinois, as we talk. We have certain guidelines in our region and our system that you as a paramedic must be able to perform as a competent paramedic. Yeah, it's been taught way back in paramedic school. They were taught and tested in paramedic school. They were able to get their state license based on that information from their education. But now their medical director is going to credential them and say, yes, you can perform these skills because you are a competent EMT. Once all this becomes complete, then you can go out and you can actually start working at whatever department or service that you work for. But this is what we define as our scope of practice. Or sometimes, when we talk about scope of practice, you can almost identify your protocols with them. So, we're going to go through all the different things that are going to be changing in the education. And as we go through this, some of the stuff you'll have seen, some has changed a little bit. So as far as underneath the category of airway ventilation and oxygenation, we're going to talk about CPAP. We already currently do CPAP, but BiPAP is going to be added into that. Chest tube, assisting. Yes, they are allowing in the National Scope of Practice for paramedics to assist a physician in putting in a chest tube. Can we monitor a chest tube? Currently, unfortunately now, per our state, you have to be a critical care paramedic in order to be able to monitor a chest tube. NG tubes, OG tubes, gastric decompression is something that, again, we have started doing along with the King, and I would look forward to, in the future, us as EMS providers in our system, because Dr. Yee is all about decompressing the gastric, the ability to go ahead and insert an NG tube when you've been intubated. Monitoring high flow nasal cannula. This is pretty interesting in the effect that there's two different types of high flow nasal cannula. One, it's someone who can't breathe, and it's a special cannula that they put on at very high rates, like 15 liters, and it helps with respiratory issues. Otherwise, we talk about high flow nasal cannula and I think that's down towards the end for we're getting ready to intubate. Replacement of tracheostomy tubes. We actually talk about this normally when we talk about special devices in our system. And I look at a lot of you guys and you guys look, oh, there's no way I'm doing that, or no, we can't do that. But yeah, we actually currently in our system can go ahead and replace a clogged tracheostomy tube. And then cricothyrotomy on the surgical. We go ahead currently and use the quick trach, but we do, is that mine that keeps, but then we do have to go ahead, let me shut this out, I think that's mine. Oh, Dan Lee is sending all of your uploads in from your reports. Okay. Yeah, we'll talk a little bit about surgical credits. CPAP, most of you guys, we already use CPAP. What do we use CPAP for in our system currently? What protocols? Pulmonary edema, right? Can be used on our COPD or asthma patients. Drowning, it can be used for freshwater drowning. And we use it a lot of times in conjunction with heart failure patients and using with nitro. How many of you guys know, though, what to set your PEEP to? What do you guys set your PEEP at when you put on somebody's CPAP? You turn it up to 10 automatically? Well, that's the way that we were always taught per our protocols. It said, as a PEEP at 10. But we know that that can be really cause a lot of problems for some people. Yes, a PEEP at 10 is perfectly fine for someone who does have heart failure, pulmonary edema, using that high PEEP. Little old ladies may not be able to tolerate it. You need to start low and work your way up. But you want to get to that PEEP at 10 when you're using the CPAP device. How about for someone with asthma or COPD? What's the max PEEP that you want to use for one of those patients? It's 5. You don't want to go any higher. You don't want to get up to that PEEP at 10 on a patient with COPD or asthma. Because remember, they have that obstructive disease, and it's not a problem getting the air in, it's a problem getting that air back out. And so by using that PEEP of 5, it's going to help open those alveoli, get the medicine down to cause bronchodilation for us to be able to have a patient who's going to breathe a little bit easier. Now, BiPAP, one other thing, CPAP is continuous flow. So whether you're inhaling or exhaling, you are getting that constant pressure. BiPAP is a little bit different. BiPAP means that when the person is resting or is getting ready to do its inhalation, it goes up, the PEEP goes up about 4 centimeters of water higher than during the exhalation phase. Because sometimes with these people with BiPAP, they can't actually force that air out. And so they get tired fighting against it. And so it kind of, the pressures change between inhalation and exhalation. And like I said, it's usually about 4 centimeters of water difference in the PEEP for it. Just understand, we've been seeing a lot of machines, they're called Trilogy machines. And people are going home with these units. And they're using them when they feel the need to. Some are constant, some are when they're sleeping. But first of all, we cannot transport those Trilogy machines, the patient on a BiPAP machine. And the other big thing is, don't think that you can take someone who is on a BiPAP machine and say, oh, okay, we can't take you on this, we'll just put you on our CPAP and we'll go. Most people that use the BiPAP machine cannot tolerate CPAP. So please remember that. You're probably going to see them plummet with their pulse oximetry. You know, could be down as low as 55 at times. Until we actually end up with our protocols having the BiPAP in there, where we would show you how to do the settings for the BiPAP machines and understanding how they work. And someday I think that BiPAP will end up being in our protocols. A lot of CPAP machines will have that BiPAP-CPAP combination. So as we move forward, I mean, currently we're using disposable CPAP, but I think as we start to move forward, and we'll go back to buying machines, we're gonna see them be in a combination of Bi and CPAP. But the big thing to remember with the BiPAP currently is that if they do have that Trilogy machine, we cannot operate it. It's always a good idea, family members, if you wanna keep the patient on it, a family member rides in the back of the ambulance so that they can go ahead and monitor the machine. And they're well versed in it and they're well trained. And it's just like any of the other equipment that you might see on some like these high-tech kids or some of these patients that are on home health and they have some of these machines. Family can usually go ahead and run them. But yeah, BiPAP is a good machine, but we just cannot use it right now. Chest tube monitoring. I didn't go into the chest tube insertion because even our critical care paramedics do not insert chest tubes in the field. Yes, if they are on a flight team and they've got a doctor there, yes, those flight teams will go ahead and assist in putting in a chest tube. Mainly we use a chest tube for someone who has a pneumothorax, hemothorax, or a combination of both. Those who have empyema. Empyema is the, I call it kind of a lung butter that's in between the visceral and the parietal pleura. And it's kind of a thick, mucousy type material that you will see come out. It's really a bunch of infection that's in there. And so they will put a chest tube in these patients in order to go ahead and help reinflate the lung, or to drain out any of the infection, the pus, or the blood that might be in the pleural cavity. This device right up here, this is a dry vac. It used to be that it was a wet vac, and you had the tube that came from the patient, and it went into a collection or a chamber that was half filled with water. So the tube went down there, and then another tube came out through the air. So when the patient exhaled, air bubbles you would see in this collection chamber, and you knew that you were getting the exhalation and everything was good. But when they inhaled, that water seal prevented any air from going back into the patient's lungs at the time. Currently, right now, this is what we call Atrium, in which most hospitals go ahead and use, and it is the dry vac. But it is, not only is it a collection chamber here, so if someone is bleeding, if someone is got pus or infection or empyema that's actually coming out of the lungs, that will collect in this area. The other thing, it has a suction here off of this tube. You can hook it up to a very low rate of suction, which will help pull any blood or infection out of the lungs at that time into this collection chamber. The other thing we look at here is down here there's just a little bit of a water seal, and we look at that to see if it's bubbling or not. If we see bubbles in that area, we know that somewhere along the whole system we have some type of leak. Now, patients are going home with these chest drainage systems. I don't know how often that we would encounter something like that in this area, but there are some patients that are back home. It's going to be long-term that they'll have these in place, and that you need to know what to do with them or how to transport. First of all, never ever clamp a chest tube. okay, unless ordered specifically by a doctor. A lot of time by clamping a chest tube, you can actually make that pneumo or hemothorax even worse. And so that's not what we're looking to do. Second of all, this device here must be lower than the patient's heart. So if they're laying on the cot, there's little clips, you can hang it off the side of the cot to go ahead and do its collection. Want to make sure it doesn't go ahead and tip over. On the bottom, you can kind of turn the stand and it'll stand up, but the big thing is in the back of an ambulance, making sure it doesn't actually tip over. The other things you want to look at when you have a patient who might have a chest tube in place or a chest drainage system is take a look at the site itself. Is it red? Is it swollen? Is there red streaks coming from it? Does it look like there's an infection there? Is it warm to the touch? Is the occlusive dressing over that sealing it off really good? It looks kind of funny because it's a hole and then they've actually gone ahead and stitched all the skin around that tube so it doesn't pull out. Doesn't mean it can't be pulled out, it just means it's a little bit more difficult to pull it out. So you have to be very careful when you're working with all of the tubing, okay? If you see bubbling in this small area, the easiest thing is to take and the hospital should give you extra hemostats when you're transporting with this, but is to clamp it off up in this area. Even though I said don't, if you've got a leak somewhere, you've got to go ahead and try and figure out where it's at. And if we clamp off before the collection chamber, we can make the determination, is it the tube itself, or is it something in this collection center that's actually leaking at that point? Also, when you're getting ready to transport someone with a chest tube and you're monitoring, always note, what was the collection chamber at when you started? There's numbers along here, you want to go ahead and take a look. Oh, they had 250 cc's of blood when we started the transport. When you ended the transport, they had maybe 300 cc's. It is not good if they are if you end up with more than 250 cc's per hour of blood loss into this collection chamber.
Lieutenant Colbert, line 1. Lieutenant Colbert, line 1.
Put yourself. Take a look. Yeah.
Does anybody have any questions about chest tube monitoring? Like I said, I don't see this changing from a critical care skill versus something that paramedics are doing. But I know paramedics are transporting these all over the country without it being a critical care skill. OG NG tube placement and monitoring. We actually gave you OG and NG tubes for the use with the King. Everybody saw those came through, right? Gastric tubes with the King are really nice, and to be honest with you, it doesn't really need to be that pricey of a gastric tube. You can hook that gastric tube up to low suction, low constant suction if you want. Otherwise, you can just, use the suction when indicated when you start seeing the stomach get a little bit more distended. And that was the whole purpose for pre-hospital providers to use the OG or NG tube, is for gastric distension. A lot of services that if they go ahead and intubate a patient will drop an NG tube right away, because again, they can go ahead and hook up the suction and they can suction any gastric contents that may be starting to work its way up, trying to get near that balloon, and cause an increased pressure there. It can cause, if you end up having distension. Most of the time that anybody who's going to use a bag valve mask, they'll tell them, drop an NG tube right off the bat, because we do cause a lot of gastric distension when we're using the bag valve mask. The King tube too, you've got those two balloons, and there is a risk of aspiration with those, because depending on how much air you put in the balloons, a lot of it's just provider air. When they don't put enough, they're not monitoring, They're not listening to the stomach once they go ahead and have it in place and monitoring that every, 5-10 minutes just to make sure that it hasn't become dislodged. But I had talked to, Dr. Yee about an NG tube when we had gone ahead and intubated someone. Why are we not putting these down when we have patients who are in cardiac arrest or go into respiratory arrest? It's a good thing to do because then it decreases the interthoracic pressure within the chest, doesn't allow for extra pressure to be put on the heart, and the heart will pump then effectively without raising the pressure. We do have to measure this appropriately. So you want to take the end of the tube, put it just below the xiphoid process, bring it up to the nose, and then from the nose over to the ear. Once you get to that area, mark it. Whether you take a marker or whatever you use, you mark it, because you don't want to insert it any deeper than that. Otherwise, it's going to coil up in the stomach there, and it's not going to be effective. And the last thing you need it to do is start to make its way down into the intestinal tract, which definitely is not something you want to start suctioning up at that point. It's very easy to go ahead and put in once you've intubated, just because of the fact that there's only 2 holes in the back of the throat. If you have a patient who is conscious, you want to tilt the head just a little bit upward, and then as you start inserting it, you're going to meet some resistance. Always use lube, it's a lot easier on the patient, but have the patient start swallowing. If they start gagging, give them some water to go ahead and out of a straw to start drinking. If they drink water, you'll be able to go ahead and slide that NG tube right down, and it won't be any issue. Once you get it to where it needs to be, on your patients, we do have to go ahead and verify, is it in the right spot? Obviously, you don't want it to go into the lung, and that can happen. It's a small probability, but it can happen. There's a special syringe that you're going to hook up to it, and you're going to draw back on the syringe, and you're looking to see if any gastric contents are coming up that tube. And that's what you really want. If you're just getting air, it's not a good thing, because then you're going to want to go ahead and remove it and start again. But like I said, most people will drop them after they have the tube in place, just as a means to go ahead and decompress the stomach. Alright, high flow nasal cannula. This is continuous high flow oxygen, and it actually is going to wash out the back of the oral ear or pharynx, right in this area, and it's going to have higher concentrations of oxygen. It actually provides a little bit of a reservoir when you're trying to intubate, which we're going to talk about towards the end, but it gives you a little bit more for gas exchange. Remember, from here to here, you've got that dead air space, and so there is no gas exchange occurring until they get to the bronchioles. And when we go ahead and we put high concentrations of oxygen in patients who are in respiratory distress, it's very helpful for keeping their oxygen levels up a little bit. It also prevents any rebreathing of carbon dioxide, which you can see on your end title when you go ahead and take a look at it. So it decreases the dead space that you're looking at. It allows for a patient to go ahead and breathe effectively. Now, there is a special nasal cannula. When you're given this high flow oxygen, you want to make sure you're hooked up to humidified oxygen. High levels of oxygen, dry oxygen, can cause a lot of bleeding in the back of the oral pharynx. It can cause some dryness of the mucosal membranes in the nasal passages, which ultimately can lead to bleeding too. So, but it is a very good way to help increase the oxygen concentration within the blood for patients who have some type of respiratory ailment that you just can't get their oxygen saturations up there. Tracheostomy tube replacement, this scares a lot of people. When we've talked about this in the past, you know, you go into someone who has a trach. First of all, no one likes trachs because they're icky, they're messy, and if you have to start suctioning them, they can get pretty gross at times. But you have a patient who has their stoma, and then you've got the trach tube that's in place. It's got a little balloon here, sits. They can go ahead and cough, do whatever they need to do. There's something that goes around the neck to basically hold it in place. But there are times where thick mucus plugs will clog up the end here and cause difficulty in breathing. It'll also go ahead and, if they're not doing proper trach care at home, it becomes really crusty. And patients will have a very difficult time breathing. And so they'll go ahead and they'll need this replaced. Family members, they're very good. They're taught how to do this before they're sent home. But sometimes it comes down to they just maybe can't get the trach back in, or they can't get it cleaned. The most common trach that's used is a 3-part trach. You have your outer cuff here, or outer cannula. The inner cannula will go ahead and go right into the hole here and sit in the inside. And that's one of the other reasons why we see a lot of mucus getting clogged, because even though this is inside and it sits pretty tight in there, mucus does get caught on there and ultimately can create a big clog. Then you have the obturator. This is actually put into the outer cannula when you're getting ready to go ahead and put this in. The outer cannula here it's not rough, but it's not rounded and smooth. So they put the obturator in here, which causes the nice rounded end and makes it slide into the trachea a little bit easier without doing any damage. So those ridges are not getting caught on the rings of the trachea area. So what do? You've got a patient, they're experiencing some shortness of breath. First thing, go ahead and try and suction. Okay? I tell people, take your soft suction. It's right there. Go right down to probably about the middle of the chest. Take your soft suction. You don't want to go too deep. You want to try and cause a cough reflex, cause them to cough, because that will also help dislodge anything that might be in that tracheal area. This would be a very good time to put goggles on, maybe even a gown or a face shield, just so that when they cough, a lot of stuff comes flying out of there that you may not necessarily want to have all over you. First things first though, if you suction this and it's not helping, take out the inner cannula, and it's just a quarter turn, pull out the inner cannula. Beside them, they will have trach care kits, which will have sterile water. It'll have a little bit of a brush that you can go ahead and clean the inside of the tube out, the nasal cannula out. They'll tell you too, it has some hydrogen peroxide to clean that inner cannula to make sure that it's all disinfected before you go ahead and put it back in. And once this is out, you can go ahead and try suctioning that trach tube again. Now, sometimes it's just such thick mucus, it's almost impossible to go ahead and suction out. So there is also a syringe with some sterile water. Draw up about 3 mLs of water, and you don't want to slam it down there because you're really going to cause a cough reflex in your patient. But go ahead and just drip it down there. That'll help loosen up some of those secretions. And then suction on the way out. Again, remember, we don't suction any longer than 10 seconds when we're suctioning a patient. Once you're able to go ahead and clean it out, again, you can put the nasal or the inner cannula back in and put it there, secure it in place. Make sure that when you tighten the trach down, you can at least have one finger with below the trach cuff itself, right here on the sides, so that it's not going to choke the patient. Now, what happens if They have this and it is so crusty, so icky, and it really, maybe they've actually coughed it out, it's come out, the balloon's out. You can take one of the boxes that they have, and they're called Shirley tracheostomy kits, which is right there, and put it together, again, put the obturator in this main area, and you can insert that trach right back in there for them. It's just a matter of following the groove. You're gonna start with the curve here. This end would be down this area, and you're just gonna insert it so it just kind of goes right down and follows the pathway. Don't jam it if you run up against something. Just kind of pull it back and try and insert it again a little bit forward, but don't try shoving it in. And then once that's in, pull the obturator, put the inner cannula back in it, and blow up the balloon, and your patient should be able to breathe a lot easier. Now, if you don't have any extra, what's something that you could use? You could use your ET tubes, right?
A big pen.
Yep, you could go MacGyver it and use a big pen. The only problem with that is that, that can be damaging to the sun. But if you use, say for example, you use a 6 ET tube, make sure you cut that ET tube down. Otherwise, the tube itself is going to be hanging way out here. If you cut it just above the pilot balloon, don't cut it below because you won't be able to blow it up, but if you cut it just above the pilot balloon, you can actually put the connector piece back on that area, make it a little bit smaller. And then you probably only have maybe that much that's sticking out compared to what you probably have who's that much sticking out if you had to put in an ET tube instead. Some people won't feel more comfortable with that. Sometimes you can go ahead, like I said, and just replace this and it's sign off and go home.
Are you thinking our newer paramedics are already coming to us with this skill in the last couple of years?
Yep, the last 5 years since I've been teaching, they get taught this.
At St. Francis.
It is part of the new national standards, which has been taught for, well, I know that we jumped on the bandwagon and started teaching 4 years ago, or 5 years ago, the national standards. Most of the services around us, or programs around us, were teaching it about 4 years ago. So, yeah, they should be, they are taught this. We do a presentation called the Living Room ICU, which we actually give them the actual trach itself. Let them play with it, let them show it how to put it together, how to take it apart, and how to insert it into the trach. So, I know a lot of people don't want to admit they know how to do it because it is pretty gross, but they definitely are being taught this. Not just trying to think. I taught this about 6 years ago, 7 years ago too. As far as it was one of those gray areas where could we do it, could we not do it. We actually have in our protocol book now a section under special devices or special functions or something in our protocol book that talks about replacement of the tracheostomy tube. So, I don't know, I don't remember what page it is, but yeah, it's in our protocols too to be able to do it. So. Surgical crikes. These were always considered last-ditch efforts, or whenever we couldn't get an airway, go ahead and do a surgical crike. There's been different types out there. I mean, you can do, obviously, the surgical crike. They'll give you a scalpel, and you'll make your own ET tube. Again, cut it down so that you can go ahead and insert it in. But was it 2008 we finally introduced to you guys, we got rid of the Melkers and we put the Quick Trachs on the ambulance. Quick Trachs are so much better than do this. This can actually be a pretty bloody mess. Now I do know Region 9 does surgical crikes. Is there anybody that you know of Region 9 here? Do you have other people that work over there? What's that?
What is 9? Is that Northwest
It's
Community?
That's Northwest
Yeah.
Community.
Illinois Zoning Commission.
Yeah. I'm honestly hoping that we start getting aggressive with what they are. I was really excited when Dr. Yee was all set to approve ketamine for pain management and for induction of, drug-assisted innovation. And I wrote up all the training for it, and I was all excited that you guys were gonna be getting ketamine. And then we went to see how much ketamine we were gonna need, and we found out it was on a shortage list. So that was pretty disappointing, but yeah, we're hoping to start taking us to the next level. This is why we a lot of times tell people there should be no reason why you can never get an airway. I mean, obviously, if you try an ET tube, or bang valve mask isn't working, you go to ET tube. You can't get the tube, you go to the King. For some reason, the King you can't effectively ventilate, because maybe there is some type of occlusion in there somewhere, an obstruction of some type. We have the Quick Trach we can go to. Our landmarks are gonna be the same as the Quick Trach as with the surgical cric. We're trying to find that cricothyroid membrane. And we wanna make sure that we're staying midline and staying right at that membrane. Just an inch off either side, you've got some great vessels that are in that area that you could do a lot of damage. If you go much further inferior to that area, you've got the thyroid gland that's right in that area. So you do have to really watch your landmarks very closely. So you start off with, you need to have a 7 ET tube that you're gonna cut down. Again, you cut it, if the pilot balloon's hanging out, cut it just above the pilot balloon. Take off the top adapter off the piece that you cut off, and you can put that right into the area where you did cut. You need a 10-blade scalpel. Having a hemostat or a tracheal hook is good. Most people will end up having some type of hemostats. Hemostats are nice because you can open the airway. Forceps are also very good to go ahead and have to help you keep that hole open. The old school way is they actually taught us to keep our fingers in that hole, our glove finger obviously, but with all the the cartilage and everything that's in there, that's a quick and good, easy way to tear a glove. I don't always recommend that. I recommend using forceps instead. But what you're going to do is you're going to start with your subcutaneous cut, and it's going to be a vertical cut. And you're going to cut just maybe about, I would say about an inch from the cricoid cartilage down over the cricothyroid membrane, okay? Once you've cut that subcutaneous, this is where I like to take my forceps and I kind of open up that area. So then I can see directly the cricothyroid membrane. So we get this open up. You can use tracheal hooks to pull the skin. I usually just will insert forceps and kind of open this up so that I can see the cricothyroid membrane. Once I see that cricothyroid membrane, then I'm going to make a horizontal cut. And I'm just going to be about 1 centimeter long. I'm going to take my scalpel and poke into that cricothyroid membrane. And I'm going to go kind of like one little cut to the right. Keeping my scalpel in place, I'm going to turn it and I'm going to go back the other way and do just little cuts on the other side. The big thing to remember at this point in time, you don't want to remove your scalpel until you either have a tracheal hook, hemostat, or forceps in the hole of that cricothyroid membrane, because if you go ahead and you take that out, you're never going to find the hole again. So again, I'll insert the forceps into the cricothyroid membrane and I'll stretch it open a little bit. And then that's where I will go ahead and take and insert my 7 ET tube, or 6.5 works just fine. But insert my ET tube, blow up the balloon. I'll ventilate just to make sure I'm in the correct spot. And then I secure it with tape. Even though that we do have that balloon,
Oh, we're doing it, oh my goodness.
Hang on, we got a job, that's all right.
alright, you go do your job,
Job.
I'm gonna work.
Flat 29, engine 28, Columbia truck 14, ambulance 29 on fire alarm.
Oh. I come with
405
his,
Central Avenue, the job.
Yeah, how many of those did you have last week?
2913.
Too many.
405
We had
Central
20 something
Avenue.
calls.